Chairmans and dear colleague, thank you for your kind invitation. Bosch and tremor osteotomies are very well known and reported in literature. The Bosch technique is performed by two approaches, the tip of the hallux and the distal first metatarsal. The osteotomy and the percutaneous fixation are done as illustrated. This technique allows a huge lateral displacement of the metatarsal head. Distal soft tissue procedure not done, prolonged immobilization is recommended. This technique allows a huge lateral displacement of the metatarsal. The clinical results of the Bosch technique are generally very good. Nevertheless, radiographic problem after the Bosch procedure observed due to percutaneous key wire and prolonged articular immobilization. In spite of good clinical appearance, arthritic changes of hallux are sometimes observed, articular injuries and mobilization of osteotomy fragment might be observed. These X-rays might reveal a very good alignment, but articular damages are responsible for articular limitation and stiffness. This picture shows the key wire and the usual aspect of the hallux at the end of immobilization. Other drawbacks of Bosch procedure are listed as above. Since the surgery of hallux valgus is an articular procedure, postoperative immobilizations should be strictly avoided, just as in other articular districts, hip, shoulder, knee, etc. The rationale behind the modification of the Bosch technique are summarized in this slide. The striking point is the preservation of the normal range of motion after the operation. This is the technique of the Bosch modification. One mini incision on the area of head and neck of the first metatarsal. The bunionectomy as the osteotomy are performed with a micromotorized bone cutter. After the osteotomy, the metatarsal head is displaced as desired. The key wire is guided within the diaphysis through proximal first metatarsal osteotomy. The key wire is driven into the medial cuneiform to enhance stability. At the level of the first metatarsal head, the key wire is angled, cut, and turned laterally. The big toe is now pierced by the key wire, then not immobilized. Echinosteotomy of the first phalanx to the big toe is easily performed. Lateral distal soft procedure are performed if necessary. The picture and X-ray show the foot at the end of the modified Bosch. The detail of the present survey are listed in this slide. The X-ray protocol considered the correction of hallux valgus into metatarsal angle, sesamoid reduction, and healing of the osteotomy. Postoperative incomplete reduction of the sesamoid are considered a risk factor for recurrence of hallux valgus, as reported in literature. So we take a great care in checking our sesamoid reduction. The X-rays, in this case, show the advancement of bone healing. The X-rays show the correction of the hallux valgus and in the metatarsal angle, just like in this case. The case of bone healing advancement shown. Another case of bone healing and good alignment are shown. Hallux valgus recurrences can be corrected by the modified Bosch. The results show a good correction of the considered parameters from a statistical point of view. The modified bars show complication, naturally, as listed in this table, but articular stiffness of hallux joint was not the major problem. The X-rays show a rupture of the key wire. The X-rays and the picture show a postoperative hallux erectus deformity. The X-rays show at the displacement of the key wire, the hard wire remover did not compromise the final result, though. In this case of displacement of key wire, the hard wire removal was not necessary. Postoperative varus deformity is shown. Conclusion. Normal range of motion of the hallux after the operation is the main modification of the original procedure. Permanence of percutaneous key wire is avoided. Articular changes and stiffness of the first metatarsal phalangeal joint are reduced. The lateral displacement of the first metatarsal joint remain relevant. The correction of the intermetatarsal and hallux valgus angle are effective. This is a case of bilateral procedure. Bilateral procedure, as you saw, are easily feasible. The sesamoid are reduced, and so are the recurrence of hallux valgus. Only weight-bearing resumption is possible. Frequent dressing of the surgical site are not necessary. Thank you.
Thank you, Mr. Scala. We have 3 minutes for discussion. Is there any question? Don't hesitate. We are here to exchange. How many people? Yes, one question here. Micro, please. Microphone.
You have to come here. You have to come.
Go to the microphone, please.
Maybe you want to renounce.
I noted several times the parcel increased.
So what's the question? I don't understand. Please.
Ho notato che alcune volte spesso e volentieri il PASA aumenta un po', perché quando metti il Kirchner, an increase of the PASA window with the key wire.
Yeah, I remarked that too, but this not seem affect the final result. Now,
Okay, question. And what is your post-operative regimen after surgery? Do you have full weight bearing?
yeah, the day after the surgery, the patient are allowed to weight bearing, partial weight bearing weekends in a baroque shoe, and dressing of the operating side is every week, and at the end of the 4th week, everything seems fine.
You say immediate weight bearing, but baroque shoe, it is not immediate weight bearing. It's weight bearing at the bottom part of the foot.
Yeah, allow me to correct myself. They walk with a baroque shoe. Yeah, and the normal sneakers or sandals are possible to wear at the end of the 4th week.
But you think with a single track you do and one camera, you think it would be possible to have an immediate full bearing without having an elevatus of the first ray? You think it would be possible?
Yeah, I can't believe this at the real beginning. I just tried. Yes, it seems it's effective. Yeah, this is exactly what I wanted to show you. To avoid the big big key wire, then trespass the joint, try something else. Yeah, yes.
Good, thank you. Thank you. How many people do the Bosch osteotomy? Can you raise the hand, please? Nobody in the room? Do the Bosch osteotomy? You're alone?
In Italy, is largely used.
Yes.
The chief of orthopedic surgery in Italy used this technique.
Good. Thank you.
Thank you to you, Michel. Thank you.
Andrea.